Hello everybody, my name is Sydney Young and I will be giving a presentation on cervical cancer. To start off, I'd like to give a general overview of what cervical cancer is. So cervical cancer is a malignant tumor of the cervix. The cervix is the lower portion of the uterus, and the cervix connects the uterus to the vagina. So the cervix has two different parts, each that have their own types of cells. So there is the endocervix, which is the opening of the cervix that leads into the uterus. This portion of the cervix is covered with glandular cells that are involved in the menstrual cycle and help with the production of the cervical mucus. Then there is the exocervix, which is the outer part of the cervix, and it is covered in squamous cells that are thin and flat and make up the epidermis. So these two cell types can be found to meet in what is called the transformation zone, and within the transformation zone is where most cervical cancers begin. So the cells in the transformation zone do not just transform into cancer out of thin air. The cells gradually develop abnormal changes, which can be seen by doctors and are identified as precancerous. Doctors will label these precancerous changes as cervical intraepithelial neoplasia, squamous intraepithelial lesion, or dysplasia. Only some of the precancerous cases will actually develop into cancer. Some can go away without treatment, but others will turn into cancer, which will require treatment. There are two main types of cervical cancer, and these are squamous cell carcinomas and adenocarcinomas. Most cervical cancers tend to be squamous cell carcinomas, so that will be the focus of today's presentation. These cancers develop in the exocervix and most often begin in the transformation zone. I would now like to speak on the epidemiology of cervical cancer. As seen on the slide, there are about 14,480 new invasive cervical cancer diagnoses and about 4,290 deaths from cervical cancer. Cervical cancer actually used to be the most common cause of death for American women, but this rate has dropped by 40% with the increased use of pap smears. To define a pap smear, it is a minor procedure performed by doctors by gently scraping cells from the cervix just to be examined for abnormal growth. This is why cervical cancer is most often diagnosed in women ages 35 to 44 years old, and it is rarely diagnosed in anyone aged younger than 20 because you are to begin getting your yearly pap smear at the age of 21. This graph is taken from the CDC. It is the rate of new cancers by age group for all races and for female. It is for cervical cancer in the U.S. in 2017, and it's the rate per 100,000 women. So as you can see, the highest peak is in the age group of 40 to 44 years old, going all the way down at a slow decline to 85 plus years, with the smallest group being from 20 to 24 years old. This graph was also taken from the CDC, but this graph represents the rate of new cancers by race and ethnicity in females for cervical cancer in the United States in 2017. This is, once again, a rate per 100,000 women. As you can see, the Hispanic women are at the top with 8.9, and the Asian Pacific Islander women are at the lowest with 6.0 out of 100,000. There are many risk factors involved in cervical cancer. Human papillomavirus, or HPV, puts women at the greatest risk of developing cervical cancer. HPV is passed from person to person through sexual intercourse. In women, it can cause changes to the woman's cervix, leading to an increased risk of cancer. Regarding sexual history, if one has had many sexual partners over their lifetime, there is a greater risk for disease and HPV, along with having sexual intercourse at an early age, also increasing the risk of contracting HPV. Having other STDs can also increase the risk of cervical cancer. Another factor that can increase the risk of cervical cancer is using contraceptives for a long period of time, more specifically oral contraceptives. Having multiple full-term pregnancies can increase risk, especially if that first full-term pregnancy was at a younger age. as pregnancy and birth changes the uterus drastically. More commonly known risk factors for almost all cancers are smoking, drinking, diet, and family history, which can be seen in cervical cancer. When it comes to the symptoms of cervical cancer, it can often go unnoticed. In the earlier stages, there may not even be any symptoms present. It's not until the later stages of cervical cancer, when it is more advanced and more serious, that symptoms become apparent. So most often there is bleeding or discharge that is different than normal, so that would be considered bleeding or discharge after intercourse, bleeding in between periods, or bleeding after menopause. Discharge, it could be more watery, it could have some blood in it. Most likely it will also have a much stronger, more foul odor than normal. Another sign could be pelvic pain or pain during intercourse. And at any time a woman experiences any abnormal or irregular bleeding or notices a change in their discharge, whether it be consistency or smell, a doctor should be seen as soon as possible to get it checked out. Diagnosis of cervical cancer first begins with screening tests to help detect the cancer early on, even if in the precancerous stages. This includes the pap smear, which I have mentioned earlier, and the HPV DNA test, which tests the cells collected from the cervix for infection with any strains of HPV that can most often lead to cervical cancer. If cervical cancer is suspected, the next step is to have a thorough examination of the cervix using a colposcope to check for abnormal cells. During this exam, the doctor may take a sample of cells as a biopsy for further laboratory testing, which could be either a punch biopsy, where a sharp tool pinches off a small sample of the cervical tissue, or the doctor will use an endocervical curettage, which is a small spoon-shaped instrument that scrapes at the tissue to collect a small sample. If the biopsy is alarming, there are more tests that will be performed to direct the diagnosis. There's also the use of an electrical wire loop with a low voltage to obtain a small tissue sample, or there's the cone biopsy, which allows the doctors to obtain cervical cells from deeper layers, which can also be used for laboratory testing. If it is determined that you have cervical cancer, the next step in testing is staging to determine which stage the cervical cancer is in. Staging for cervical cancer includes imaging tests such as X-rays, CT scans, MRIs, or it includes visual examinations of both the bladder and the rectum with the use of scopes. As I have mentioned, the last step in the diagnosis process is staging the cancer. So there are 4 stages associated with cervical cancer, but certain stages can be further broken down. So we will begin with stage 1 cancer, where the cancer is found only within the cervix. Stage 1 cancer can be further divided into stage 1A and stage 1B. These divisions only represent the size of the tumor and the deepest point of invasion of the tumor. So stage 1 can actually be even further broken down into stage 1A1 and stage 1A2. This is once again just about the size of the tumor, and it's usually measured in millimeters, with stage 1A1 being smaller than stage 1A2 size tumors. Then within stage 1B, there is also a further division into smaller stages of 1B1, 1B2, and 1B3. In these stages, the measurements just go up from millimeters to centimeters, again with the tumors in stage 1B1 being smaller in centimeters than the tumors in stage 1B3. Then we move into stage 2 cervical cancer, where the cancer has spread from the cervix to the upper 2/3 of the vagina, or the tissue that surrounds the uterus. Stage 2 can be divided up again also into stage 2A and 2B. In stage 2A, there is a further breakdown into stage 2A1 and 2A2, which is based on size. And in stage 2B, the cancer has spread from the cervix into the surrounding uterine tissue. Then we move into stage 3, where the cancer has spread much further into the lower third of the vagina and may be causing kidney problems or could have involved the lymph nodes. In stage 3, there are 3 breakdowns. There is stage 3A, stage 3B, and stage 3C, each one with increasing in severity of where the cancer has spread to in the body. Lastly, there is stage 4 cervical cancer, and in stage 4, the cancer has spread beyond the pelvic region and is lining the bladder or the rectum, or has possibly spread to other parts of the body. Stage 4 is only broken down into stage 4A and stage 4B. with stage 4A representing cancer in nearby organs such as the bladder and the rectum, and stage 4B being qualified as cancer that has spread to other parts of the body like the liver, the lungs, etc. So in this representation, stage 1B is shown. Here you can see that the yellow region represents the growing tumor as the cancer progresses from early to late stage 1B and eventually progresses to stage B, with the tumor taking up most of the area in the cervix and starting to spread into the surrounding uterine tissue, causing further problems and requiring a heavier treatment. I'm now going to switch gears and begin to talk about the oncogenes of cervical cancer. The cervical carcinoma has most often been found to be associated with carrying fragments of the HPV genome integrated in the DNA. What was identified was that among the HPV genes that are discarded or disrupted during chromosomal integration, the viral E2 gene is one of those that is discarded. The viral E2 gene is responsible in suppressing transcription of viral oncogenes, and in its absence, viral E6 and viral E7 oncogenes become actively transcribed, which drives the cervical epithelial cells to neoplastic phenotype. Here is a representation of the viral genes involved in cervical cancer. You can see the human papillomavirus first, which causes damage to the DNA, thus promoting the absence of E2, which causes the activation of E6 and E7, with E6 binding to the tumor suppressor gene P53 and E7 binding to the PRB protein, thus in turn causing an inhibition of apoptosis and cell proliferation, all which are common causes of cancer. It has also been found through research that the WNT signaling pathway may play a role in cervical cancer. It was found that mutated WNT ligands are heavily evident in cervical cancer, specifically WNT7A, WNT5A, and WNT11. These were identified from biopsies and related to the cell lines of cervical epithelial cells. WNT11 explicitly was found to correspond with the progression of cervical cancer. Beta-catenin has been seen to accelerate HPV type 16 cervical carcinogenesis in transgenic mice, which leads to the belief that beta-catenin plays a role in cervical cancer as well. The viral genes E6 and E7 that I mentioned in the previous slide can be seen to upregulate the expression of beta-catenin, only further increasing the chance for an increase in cell proliferation. More research needs to be done on the effect of the WNT signaling pathway in cervical cancer. However, it can currently be used as a marker to indicate cervical cancer, as it does play a known role in the development of this cancer. Treatment depends on many different factors, such as the stage of the cancer and any other health problems that may cause problems when it comes to treatment. Typically, surgery, radiation, and chemotherapy are used, and some are used in combination. Generally, in early stages of cervical cancer, surgery is the first form of treatment. If the cancer is very small, it can be removed using a cone biopsy, which only cuts out the cancer and leaves the cervix intact. So this allows for pregnancy in the future if it is so desired by the patient. On more serious occasions, a tracheolectomy may be performed, which completely removes the cervix. The uterus still remains, so again, there is possibility of becoming pregnant in the future if the patient does desire. Then there is hysterectomy, which removes both the cervix and the uterus, which is the most effective as it can cure early stage cancer, and it does prevent reoccurrence of cervical cancer. However, it removes the uterus, so there is no chance of becoming pregnant after the procedure. Radiation is another common treatment of cervical cancer. It can be given externally by directing a radiation beam directly at the affected area of the body, or it can be done internally by placing a device with the radioactive material directly into the vagina, only for a few minutes at a time. On more serious occasions, radiation can be done both externally and internally. Radiation does have the drawback of causing menopause, so it is not recommended if you might want to become pregnant after your treatment. Chemotherapy is another form used to treat cervical cancer. So it is a drug treatment that is used to kill the cancer cells, and it is most often administered through a vein or taken in pill form. Most often, when two treatments are used in combination, it is radiation and chemotherapy, and the chemotherapy is used at a very low dosage. Targeted therapy focuses in on blocking specific weaknesses presented by the cancer cells. So this is most often used in combination with chemotherapy as well. And lastly, there is immunotherapy, which is a form of treatment. This is another drug treatment that works to help the immune system fight off the cancer. This one is typically used in cervical cancer when it is in a more advanced stage. These are all of my sources that I used to put together this presentation. That is all I have on cervical cancer. Thank you so much for listening, and I look forward to hearing your feedback.